Welcome to this Step 3 clinical management review on altered mental status test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam when a patient presents confused, drowsy, or unresponsive, and teach you how to pick the right answer quickly and confidently. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the neurology and emergency medicine sections of your primary board review book and your question bank before or alongside this video. If you find this helpful, please like and subscribe and check out our expert tutors and residency advisors at roadmaptoresidency.com. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for altered mental status. Next, we will apply specific strategies for questions about the differential diagnosis, the glucose and imaging decisions, and stroke code activation. And finally, we will master the next best step question format for diagnosing and managing the confused patient. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the AEIOU TIPS differential. When a stem opens with a confused or unresponsive patient, do not panic and do not start guessing. Instead, run the mnemonic in your head so you can sort the clues into buckets. The vowels are your fast metabolic and toxic causes: alcohol, electrolytes, insulin meaning high or low glucose, oxygen and opiates, and uremia. The letters cover the structural, infectious, and emergent causes: trauma, infection, psychiatric, and stroke or seizure or shock or poisoning. The exam writer is always hiding one of these in the stem. Your job is to read for the buzzword that drops the patient into one bucket, then act on the most dangerous reversible cause first. Strategy 2 is separating delirium from dementia from encephalopathy, because the boards test this distinction constantly. The single most powerful discriminator is the time course paired with attention. Delirium is acute, over hours to days, with a fluctuating course and impaired attention. The stem will say waxing and waning, inattention, and there will be a trigger like an infection or a new medication. Encephalopathy is simply the term for the brain dysfunction driving that delirium, most often metabolic or toxic, so treat the two as linked on exam day. Dementia is the opposite: gradual over months to years, progressive, with attention preserved until late, and a normal level of consciousness. So when you see an acute change with inattention, choose delirium. When you see slow decline with intact attention, choose dementia. That one rule answers the majority of these questions. Now let us go through high-yield stem recognition, the three patterns that show up again and again. The hypoglycemia stem is a diabetic patient on insulin found confused or unresponsive, often diaphoretic and tremulous. The exam wants a rapid fingerstick glucose first and immediate dextrose, because this is the reversible cause you can never miss. The acute stroke stem is a sudden focal deficit such as facial droop, one-sided weakness, or slurred speech, with a known last known well time. The exam wants you to activate the stroke code and get an immediate non-contrast head-computed tomography scan. The meningitis or encephalitis stem is fever, headache, neck stiffness, and confusion. The exam wants a lumbar puncture, but it is really testing whether you give antibiotics and image first when there are focal signs or immunosuppression. Learn these three and you will recognize most stems instantly. Let us work through our first practice question. A 68-year-old man is brought in after his wife noticed sudden right-sided weakness and slurred speech that began 45 minutes ago. He is awake but confused. His blood pressure is elevated and his fingerstick glucose is normal. What is the most appropriate next step in management? Notice that the question already gave you a normal glucose, which is a clue. Take a moment to commit to an answer before we walk through it together on the next slide. Let us break this down step by step. Step 1. Spot the pattern. A sudden focal deficit with a known time of onset and a normal glucose that rules out the most common mimic. This is an acute stroke until proven otherwise, and that normal fingerstick was placed there on purpose to push you past hypoglycemia. Step 2. Apply the rule. The first imaging study in suspected acute stroke is always a non-contrast head-computed tomography scan to rule out a bleed before any thrombolytics are even considered, and you activate the stroke code in parallel so the team moves together. Step 3. Eliminate wrong answers. A magnetic resonance image is more sensitive but too slow to be the first step. Aggressively lowering blood pressure is wrong. because permissive hypertension is allowed in acute ischemic stroke. Giving thrombolytics before imaging is dangerous and never the first move. The correct answer is B. Activate the stroke code and obtain a non-contrast head-computed tomography scan. Here is our second practice question. A 72-year-old woman with diabetes on insulin is brought in by her family for confusion that began this morning. She is diaphoretic, tremulous, and difficult to arouse. Her airway is intact, and she is breathing normally. What is the most appropriate next step in management? Think through this one carefully. The clues are a diabetic on insulin, sweating, and tremor. We will walk through the answer next. Let us work through this answer. A diabetic patient on insulin with diaphoresis, tremor, and acute confusion is hypoglycemia until proven otherwise. Now look at what the question tells you. Her airway is intact and she is breathing normally, which makes naloxone and emergency imaging distractors. A lumbar puncture has no role here and would only delay the obvious reversible cause. So why does rapid glucose come first? Because for any patient with altered mental status, a rapid fingerstick glucose is one of the very first actions, right alongside airway, breathing, and circulation. It is fast, it is cheap, and it identifies a cause you can reverse in seconds with dextrose. The correct answer is A. Obtain a rapid fingerstick glucose. Burn this into your memory. Glucose is checked early on every confused patient. Let us review the initial workup for the boards, because the order of operations is exactly what these questions test. For every altered patient, the reflex sequence is airway, breathing, circulation, and then a rapid fingerstick glucose. Memorize glucose as an early reflex because the exam rewards it again and again. Next, imaging. A non-contrast head-computed tomography scan is the first imaging study when you suspect a stroke, a bleed, or trauma, or when there are new focal neurologic signs. Imaging also comes before the lumbar puncture whenever there is concern for raised intracranial pressure. Now for the lumbar puncture itself. Reach for it when the stem suggests a central nervous system infection, such as fever with headache and neck stiffness, or unexplained altered mental status after the reversible causes are excluded. But if there are focal deficits, new seizures, immunosuppression, or papilledema, get the head-computed tomography scan before the TAP. And when meningitis is suspected, give antibiotics before imaging, so that treatment is never delayed waiting on a scanner. Here is our third practice question. An 80-year-old man admitted 2 days ago for a urinary tract infection becomes acutely confused overnight. His family says his memory was completely normal at baseline. He is inattentive, drowsy during the day, agitated at night, and his confusion waxes and wanes. What is the most likely diagnosis? This is a classic discrimination question. Pay attention to the time course and to whether his attention is impaired. We will walk through it next. Let us break down this answer. Spot the pattern first. Acute onset, a fluctuating course, inattention, and a clear trigger, which here is a urinary tract infection in an elderly inpatient who had a normal baseline. That combination is the textbook picture of delirium, and the waxing and waning course with daytime drowsiness and nighttime agitation is the giveaway. Now the key distinction. Dementia is gradual and progressive with attention preserved early, which simply does not fit an overnight change. Depression can mimic cognitive change, but it does not cause a fluctuating, inattentive course tied to an infection. Lewy body dementia does have fluctuations, but it is a chronic baseline, not a brand new overnight event in a previously sharp patient. The correct answer is B, delirium. Whenever you see acute plus inattention plus a trigger, choose delirium. Here is a critical test-taking pearl about imaging before the lumbar puncture. Get a head-computed tomography scan first whenever the stem hands you any of these red flags: a focal neurologic deficit, a new onset seizure, a severely depressed level of consciousness, immunosuppression such as human immunodeficiency virus, papilledema, or age over 60. These features raise concern for a mass or for elevated pressure, where an immediate tap could be dangerous. Now here is the sequence the exam loves to scramble. When you suspect bacterial meningitis and red flags are present, the order is blood cultures, then antibiotics and steroids, then the head-computed tomography scan, and only then the lumbar puncture. Notice that antibiotics are given before imaging, because treatment is never delayed for a scan. Memorize this exact order, because the question will rearrange the steps and ask you which one comes next. That wraps up our review of altered mental status test-taking strategies for Step 3 clinical management. Remember to review the neurology and emergency medicine sections of your primary board review book and your question bank, and focus on the differential diagnosis, the rapid glucose and imaging decisions, the stroke code pathway, and the delirium versus dementia distinction we covered today. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.